Welcome back. This is your emergency medicine reading roundup for the week of May 4th, 2026. A quick tour of what's worth your limited attention, what might change practice, and what deserves a healthy dose of skepticism. Here's the map for today. First, the headline study. Should we stop starting adenosine at 6 milligrams for stable SVT and just go straight to 12? Then a couple of foam picks, including an updated approach to crashing pulmonary embolism. After that, we'll step a bit outside the ED to talk about diagnostic delays in pediatric stroke and what that means at triage. Then a major journal trial on semaglutide and alcohol use disorder in patients with obesity. And we'll finish with a methodology flag, an observational study on a ventilation device in out-of-hospital cardiac arrest that's likely to generate more confidence than it deserves. Let's start with the highlight. Initial 12 milligrams versus 6 milligrams adenosine for supraventricular tachycardia in the emergency department. This was a single-center prospective observational study, and they used propensity score matching to try to make the groups comparable. They looked at hemodynamically stable SVT patients and compared what happened when clinicians chose 12 milligrams first versus 6 milligrams first. After matching, they ended up with 104 patients in the analysis. The big result: first dose conversion was about 83% with 12 milligrams versus about 54% with 6 milligrams. That's a large absolute difference. The adjusted odds ratio was just over 4 with confidence intervals that didn't come anywhere near 1. Put another way, the number needed to treat was about 3.8 to get one additional first dose conversion if you start at 12. What about harms? They didn't see a meaningful difference in adverse effects between the groups, and recurrence was actually lower in the 12 milligram group, around 1.4% compared with about 10% in the 6 milligram group. Now, before anyone declares victory, this is still observational evidence. Propensity matching helps balance measured variables, but it can't magically control for things that weren't captured. And the biggest unanswered question is, why did the treating physicians pick 12 versus 6 in the first place? Was it body habitus? Was it a sense the patient looked more SVT-ish? Was it a history of failing adenosine before? Those factors could influence the dose choice and also the likelihood of conversion. It's also single-center, so it's not automatically generalizable. But there are reasons it still carries weight. The effect size is big. The confidence interval is reassuring. And the safety signal didn't worsen with the higher starting dose. Plus, adenosine lasts seconds. From a pharmacology standpoint, a bigger first push is not crazy, especially when you consider the alternative is often a second dose anyway. So what's the practical takeaway? This doesn't prove, beyond all doubt, that 12 is superior to 6. But it seriously challenges the reflexive 6 milligrams first, always, that many of us were trained on. If you're treating an adult with stable SVT and no obvious reason to be conservative, there's a strong signal that starting with 12 milligrams improves first-pass success without adding risk. Next up, the foam radar. First is EMCrit 424, the 2026 Crashing PE Update. It's a knowledge translation episode with opinions clearly labeled as such. The strength here is that Weingart is integrating multiple levels of evidence, guideline updates, plus newer studies like Stratify and HI-Pytho, and he's fairly transparent about what's solid and what's shaky. If you manage crashing PE with any frequency, the value isn't just the data points. It's having a coherent mental model of what you're trying to do in the first 5 to 15 minutes, defining the shock state, thinking through reperfusion options, aligning with what your institution can actually deliver, and not overpromising certainty where evidence is thin. It's worth a listen. If you don't have access right now, an episode should land on their foam feed soon, so keep an eye out. The second foam item is the Journal Feed Weekly Wrap-Up, which is basically a curated scan of what's being discussed. A few items that stood out. There's more on ipratropium in asthma, revisiting an old question with newer evidence. There's a sobering summary on prolonged pediatric CPR in out-of-hospital cardiac arrest, with outcomes after 15 minutes without ROSC being extremely rare, under 1%. And there's discussion of a simplified PE and D-dimer approach, using a D-dimer cutoff of 1,000 when PE isn't your top diagnosis, essentially when pretest probability is low. That last one is the kind of thing that could meaningfully reduce imaging, but it's also easy to overapply. The bottom line for now is, Interesting and potentially practice-changing, but it's not quite set it and forget it. Keep watching this space, especially the evolving data around the so-called adjust unlikely strategies. Now let's move to adjacent specialties, because sometimes the most useful ED lessons come from outside our journals. There was a Swiss registry study looking at diagnostic delays in pediatric acute ischemic stroke over 24 years. This is retrospective registry work, so we're not talking about intervention-level evidence, but it's still highly relevant. The number that hits you first is the median time to diagnosis, about 27 hours. And more striking, roughly 3/4 of pediatric strokes were diagnosed after the thrombolysis window. That's not a small gap. That's a systems-level miss. What predicted longer delays? Younger kids, posterior circulation symptoms, and vague or nonspecific presentations. That last part feels painfully familiar. Dizziness, vomiting, gait issues, altered behavior, headache. In adults, we already struggle with posterior strokes. In kids, where stroke is rare and mimics are common, the index of suspicion is even lower. They also found something actionable: direct presentation to a stroke center shortened time to diagnosis. That implies that route and recognition matter, not just the biology. The limitation here is that it's Swiss data, and your local context might differ, but the theme is universal. If you want an ED takeaway you can actually use, it's this. Keep stroke on the table for kids with unusual neurologic presentations, especially when you see focal findings, persistent deficits, cranial nerve issues, ataxia, or a story that doesn't neatly fit migraine, intoxication, infection, or functional symptoms. Pediatric stroke is uncommon, but the cost of missing it is enormous, and the data suggests we're still missing it often enough that it's worth a deliberate mental check. Onto the major journals scan, a randomized, double-blind, placebo-controlled trial in The Lancet looking at once-weekly semaglutide versus placebo for patients with alcohol use disorder who also had obesity. This is level of evidence 2 territory, a real RCT, and it matters to emergency clinicians for a simple reason. GLP-1 agonists are everywhere now, and alcohol use disorder is everywhere in our waiting rooms. In this trial, semaglutide at 2.4 milligrams weekly reduced heavy drinking days more than placebo over 26 weeks. The numbers were a 41 percentage point reduction with semaglutide versus 26 points with placebo, so an absolute difference of about 14 percentage points, statistically significant. Retention was reasonably good, with about 81% completing the trial. Side effects were what you'd expect, mainly GI symptoms, more common with semaglutide, generally tolerable. There are important caveats. It was single-center. Everyone had comorbid obesity, so you can't automatically apply this to all patients with alcohol use disorder. And 26 weeks is not a lifetime when you're talking about a chronic relapsing condition. Still, the effect is clinically meaningful, and the proposed mechanism is plausible. GLP-1 signaling may affect reward pathways, not just appetite and weight. Will this change what you do in the ED tonight for acute intoxication, withdrawal, or alcohol-related trauma? No, but it may shape what medications patients are on, what side effects they're experiencing, and what the outpatient landscape looks like in the next few years. At minimum, it's another reason to be fluent in GLP-1 adverse effects and to recognize that these drugs may be moving beyond diabetes and weight loss into broader behavioral health applications. Finally, the methodology flag, a multi-center observational study in resuscitation on out-of-hospital cardiac arrest ventilation using continuous flow insufflation of oxygen, the Busignac device, compared to bag valve mask ventilation. The attention-grabbing headline is that CFIO was associated with worse neurological outcomes. Here's the problem. This is the classic trap where an observational comparison looks like it's about devices, but it's really comparing systems. Different EMS agencies or systems adopted different strategies. Those systems may differ in response times, training, protocols, patient mix, hospital receiving capabilities, and overall resuscitation quality. That's massive, system-level confounding, and it can easily swamp the device effect. On top of that, the study doesn't really tell you how well either method was performed. And with ventilation, technique is everything. A perfectly used BVM and a poorly used BVM are essentially different interventions. Same for CFIO. Registry data also brings the usual limitations: missingness, inconsistent definitions, and uneven data quality. So the right interpretation is not CFIO causes worse outcomes. The right interpretation is this raises a question. It generates a hypothesis that CFIO may not be equivalent, and it highlights a broader point we should keep repeating in emergency medicine. Physiologic plausibility and surrogate endpoints are not substitutes for patient-oriented outcomes. If a new airway adjunct spreads widely, it deserves proper randomized evaluation before we assume it's at least as good as what we already do. Let's wrap it up with the take-home points. 1. For stable adult SVT, there's a strong observational signal that starting adenosine at 12 milligrams improves first-dose conversion without extra adverse effects, and it may be reasonable to adopt in routine practice while we wait for more definitive trials. 2. Crashing PE management is evolving, and the EM CRIT update is a useful synthesis if you want a structured approach with evidence quality kept in view. 3. Pediatric stroke diagnosis is still delayed far too often, particularly in younger children and posterior circulation presentations, so keep your suspicion threshold lower than your instincts might suggest. 4. Semaglutide may have clinically meaningful effects on heavy drinking days in patients with obesity and alcohol use disorder, which won't change ED acute care today, but will matter for the patients we see and the meds they're on. And 5. Be cautious about observational device comparisons in cardiac arrest, because you're often comparing entire EMS ecosystems, not just hardware. That's it for this week's emergency medicine reading. If you want one thing to try on your next shift, it might be the 12 milligram first mindset for stable SVT, paired with a quick reminder to yourself that kids can have strokes too, especially when the story feels off. See you next week.